our Q and A with an epidemiologist. We have today Miss Margaret Werner, Miss Werner, who is an epidemiologist for the CDC. And I guess Miss Werner and I met in graduate school at Tulane, and so you were where she was studying epidemiology, and is it an MPH or is it MS?
An MPH, Master's of Public Health.
All right, a Master's of Public Health in Epidemiology. And since then, after graduate school, she was a Peace Corps volunteer in Ethiopia.
Yup.
All right, and then, oh wait, and you're originally from Wisconsin.
Yes.
Right? But Sheboygan?
Yeah, wow, that's an amazing memory.
No, I just remember that from when we were in Uganda and at dinner that one time with all my coworkers, and I think they're all like, oh, she must be from Wisconsin because I don't know what you said, some word. Sorry.
Yeah. Weird words, strange accent.
And so after the Peace Corps, then you did a fellowship with the CDC, right? Was that right after you did the Peace Corps?
Yes.
Okay. Or actually, why don't you just your kind of career path so far, what led you to where you are now, I guess.
Sure. So, as Ms. Owens was saying, I started out in graduate school at Tulane in New Orleans. I worked on some public health research there while I was studying, and from there I went into the Peace Corps. I lived in Ethiopia for 2 years, and I worked at a health center there. I did a lot of outreach for people who were positive for HIV. After that, I came to work at the CDC as a fellow. I worked in HIV again on multiple projects all across Africa. And after that, I took a position with the CDC Foundation where I worked on typhoid immunization programs. And since then, I've been working in the same division, the Global Immunization Division. Now I work in polio vaccines, still working in Africa, making sure that programs work well to provide access to as many children as possible to make sure that they are vaccinated or immunized for polio. So I will stop there.
All right. And so I think our first question would be, what made you want to be an epidemiologist?
Yes, that's a great question. And I think I should start out with defining epidemiology, because I think that it's a subject that not a lot of people are easily or familiar with. So epidemiology is the study of the distribution and determinants of health-related states or events like diseases in specific populations, and the application of this study to the control of health problems. So in simple terms, that's like saying the study of what infects or determines a disease, and then how it spreads within a population. And then from there, it branches out into lots of diseases and lots of different areas.
Too big, so I'm trying to make it smaller.
I think someone was unmuted. Can you please make sure you're muted unless you have a question? I think they're muted now. Thank you. Yeah, I think that's great. We didn't actually get a chance to talk about that specifically today. And I know you guys, everyone knows. It's so funny because epidemiologists have been so big in the news this year, and I'm not sure if everyone really who hears about them knows exactly what they do. So thank you for that. And I know everyone knows that doctors treat like the individual diseases of their patients, but epidemiologists look and study on ways to how diseases spread and impact population or people on a population or whole level. And so they might be looking at ways to, like with COVID, stop the transmission and spread or help improve outcomes for patients, but on population levels. Okay.
Yes. Thank you.
Right.
So epidemiologists are sometimes referred to as disease detectives. And we're trying to understand disease transmission and are trained to recognize, control, and prevent the existence of disease within a population, just like Ms. Owens was saying. So when I discovered epidemiology, I think it was sort of in college, graduate school, I started to understand it more, what the work looked like. And it was very exciting and it's very dynamic. Like there's a lot going on. There are many different fields of epidemiology that you can work in and different ways to work in it. So I think just like the idea that you can work in something that's constantly changing, you're always working on something new and challenging. And like Ms. Owens was saying, you're working on something that impacts the health and the welfare of a lot of people, right? Like people who are responding to COVID-19 right now, they're working to protect the health of the whole country versus like a doctor who just treats it's a big job, who serves a patient, right? So you're working to serve large communities of people. And that's something that I was attracted to. It seemed very appealing because I knew I wanted to do something to, serve the community, do greater good, contribute to society. And so epidemiology was really appealing.
And I think you had touched on that you first became interested in epidemiology in college. And I know that we just had a question. So what did you study in undergrad?
Yeah, so I got a Bachelor of Science in Health Information Management. So I studied research methods and sort of just understood at like a facility level what kind of data health systems look at in order to evaluate their service and make sure that they're providing top level care. And if they're not, identify ways to improve service and just measure outcomes.
Oh, okay. I really like what you said because I think it's important. Everyone's heard about epidemiologists since the COVID-19 pandemic, but there are epidemiologists who work on, as Ms. Warner said, in many different fields and in many different types of epidemiology. And so in most major hospitals will have epidemiologists on staff to either work on, as Ms. Werner was saying, ways to improve some of their health outcomes and and identify maybe risk factors or gaps in their care and ways to improve how they're treating patients. And also on research, whenever a university or a hospital is conducting research studies, a lot of epidemiologists working on vaccine or clinical trials. Most local governments have health departments have, well, not most, most, I guess, major public health departments will have epidemiologists on staff year round to help serve just routine diseases that come up and for regular routine public health monitoring. And I guess, why don't you then, I guess we can segue, you touched on a little bit on what you worked on before COVID, you were pulled onto COVID-19. And I guess, I know since you worked on HIV, could you talk a little bit more about just your work on HIV since we're talking about viruses right now?
Sure. So viruses are such a cool topic. And I think that HIV is a fascinating disease. It's tragic also, but it's very interesting. I worked in HIV work and research for around 5 or 6 years. And so HIV is an infection that's, sexually transmitted. I'm sure all of you know that. And there are so many different areas you can work in. So I've worked on projects that you look at data in order to understand how your patient population is taking their medication, right? So most people, when they're diagnosed with HIV, they start an antiviral treatment or regimen. And so they take antiviral drugs on a routine basis, and that is very essential for the monitoring of the disease. It doesn't advance. So some of the work that I did included reviewing patient charts to see if they were taking their medicine, because if they didn't, they could get super sick and maybe even die. So I worked on projects like that, and then trying to understand why patients weren't taking their medicine. So if they live too far from a health facility or a pharmacy, or if the medication was too expensive. So that was one thing I did. I worked on a national survey to understand prevalence of HIV. So in Uganda, we conducted a survey where a sample of the entire country's population was tested, and then you understand in a country what percent of the population has HIV, right? So if your population has 2 million people and you understand that 4% are HIV positive, then that really influences how you reach out to those people, or maybe you're not capturing all of them and then you need to test more. So HIV is a very large field, and there are a lot of I guess subfields of work. And yeah, I think that I don't know, does that, is there anything else specifically that you want me to touch on?
No, I think that's a good overview. And I guess you guys, epidemiology can take you anywhere. I mean, you could just work locally in a hospital, but it can take you all over the world. I mean, where all have you been since you've been working with the CDC?
Oh man, it's a very long list. So I lived for a year in Uganda. I had projects in Malawi and South Africa and Vietnam and Laos and Ethiopia and Kenya. And it's a long list. And I feel like I've been very fortunate because this work is so meaningful, and I also get to see the world, which is really incredible. So yeah, epidemiology there's a lot to offer.
And I guess now we'll just, transition specifically to your work on COVID. And so you said that you were working on the polio vaccine program before, or that's still your current, I guess, job, right? Title, right? In that division? Okay.
Right.
All right. And so can you maybe talk us through how you were either assigned or volunteered to work on the COVID response?
Sure. So in my day-to-day job, I am a polio epidemiologist. I work in the global immunization division. And when COVID hit, they asked all epidemiologists and a lot of, public health professionals, like, can you take a break from your day job? CDC needs you to come to support the COVID-19 response, because that's a high priority for the country, to make sure that the disease is under control. And then when the vaccine creation started, or vaccine development went underway, they pulled people specifically from the global immunization division to help on the vaccine planning. So right now I am coordinating the southeastern states, so like Georgia, Florida, South Carolina, North Carolina, Tennessee, Florida, helping them to get their vaccine and immunization departments in order, so that when a vaccine is ready for COVID-19, that we can ship it to the capital city in most places, and then from there they distribute it to the counties throughout the states. But there's a lot of planning that takes place for that. So if a company who's developing a vaccine develops 1 million vaccines, you can imagine that that's only going to go so far in the United States. So we have to prioritize who gets the vaccines. So Mississippi, for example, has 1% of the country's population. And so if a company makes 1 million doses, then what they're thinking right now is 1% of those doses will go to Mississippi. And then from there, because that won't be enough to cover everyone in Mississippi, for the first round of vaccines, they'll say, okay, this is how many we're getting. Now let's figure out who should get them, right? Because our grandparents are the ones who are very much at risk for this disease or from getting, you know, advanced disease. And so we figure out to the community level how many vaccines should go where and how do we make sure that people have access. Another population that is really important are healthcare workers. We want to make sure that healthcare workers get vaccinated so that they can stay strong and healthy and then can continue to provide healthcare to COVID patients.
Mm-hmm. Yeah, and someone was outside my door and I was just distracted. Sorry. And so at what point for the vaccine, at one point does CDC do you work with the state and county health departments all the way to that level? Or at some point do you just kind of hand it off, get it to the state, and then the local health departments handle it? Or are you involved the whole way through?
So because the current political administration has made this such an agenda for the government, we're working with the federal level, so people in Washington, D.C., and then trickling all the way down to the state level. So I have meetings with Mississippi every day, or not every day, but like once a week, and we say, how's your planning going? They're the ones who coordinate with the counties within Mississippi to understand the need at the county level. And then I think from there, eventually it will fall all on the states. But I think until there is vaccine that is available for everyone, we'll continue to work with states to make sure that the top priority people receive the vaccine, that the vaccine is, you know, shipped and gets to the right places at the right time, and that it's managed in a way that is responsible and efficient. So yeah, I think it's a process, and right now it's all planning because the vaccine's not ready. So it's a lot of coordination and data crunching.
Oh, and I like your comment, so about the supply chain, I guess, challenges or getting it from point A to point B. Made me think of, so as Ms. Werner said, so in a public health emergency, we have all these people who are working on their normal day-to-day jobs, and it's just, you have to task shift and reassign people to where there's the need. And so that's also why everyone knows who Dr. Birx is now. She's been on the news all the time, but she actually was picked because of her experience working on the global HIV response. It actually kind of under where I guess we both worked, kind of under her purview back a few years ago on HIV. But because when Ms. Werner was talking about the challenges of someone who's diagnosed with test positive for HIV on their meds, if you're in a country where there's a poor road system or poor supply chain issues, there are a lot of other kind of just access challenges that she was touched on about just being able to physically get drugs there. And so there's a lot of coordinating and planning that has to be involved in any epidemic or pandemic. But
yeah, and then there's an added level of complication with vaccines because they have to be kept at a certain temperature. So one of the vaccines that's under development is ultra cold, and it has to be stored at a -60 to -80 degrees Celsius temperature for a certain amount of time. Or if it leaves that temperature, the vaccine is spoiled and it gets wasted. And so that adds a level of complication because, not every health department, like you said, has an epidemiologist, and definitely not every health department has a freezer that can store vaccines at this temperature. So there are a lot of considerations to take in the planning process.
And all right, let me just look at our other questions. And so I think you kind of touched on what your day-to-day job is like. But I know before you came onto Operation Warp Speed, you you did do one or two kind of tours, or what would the word be, where you went to actually help like a local health department on the response.
Deployments. So
Deployment.
So before I was asked to take this position with the vaccine planning team, I guess I volunteered to support domestic state department or state health departments. So my first deployment was to the Washington State Department of Health, and that was really cool. I went and worked in Seattle. They have a sort of like a wing of their health department. And what we did was work on the long-term care facility data and sort of program planning, because also in the news during the beginning of the outbreak, a lot of nursing homes were having their own outbreaks, right? Like older people who are extremely vulnerable and vulnerable, were getting sick, and there were outbreaks in a lot of long-term care facilities, so nursing homes and skilled nursing facilities and adult living homes. And so they wanted to understand the transmission of the infection among those long-term care facilities. So what we did was look at the data, examine the cases, look at healthcare workers that were delivering care in some of those facilities, because healthcare workers were going in between facilities. So maybe someone would work the morning in nursing home A, and then they would go spend the afternoon in nursing home B. So that person can transmit disease between facilities. So that was a very interesting deployment. And Washington State it was really, the outbreak was very bad in the beginning, and they've done a lot to get it under control. Then my second deployment was to Navajo Nation, which spreads across a few states in the United States, but I deployed to Arizona. I was a few hours north of Phoenix, and I was in a very, very small remote town called Tuba City. And I worked at the hospital there. That city does not have a health department, and they don't have any epidemiologists. And so the doctors in the city were trying to support, the outbreak in the reservation area. So among all of the Native Americans in this area. And Native Americans have also been a very hard hit population during COVID-19 because they have a lot of pre-existing conditions. So I think you probably have also seen on the news, if you have comorbidities, you're likely to get much more sick if you get COVID. So if you're overweight or if you have diabetes, then if you get COVID-19, you can become much more sick, and then the likelihood of death is higher. So what we did there was a lot of contact tracing. So what that means is you go to someone's house who recently tested positive for COVID, and you interview them. Who have you come into contact with since you started having symptoms? And then once you have these lists of people, you reach out to them and say, you've been exposed, you should go get tested. And then it's sort of like a trickle down effect. So then that person goes and gets tested, and maybe 3 of the 6 people that person had come into contact with test positive. Then you interview them and you say, okay, who have you come into contact with? And some people aren't even showing symptoms. So those asymptomatic people who test positive are even trickier, because if you don't show symptoms, then you don't know how long you've been carrying the disease, and you don't know how far back you want to identify people that you've come into contact with. So COVID-19 has been a really interesting time for epidemiologists because it is so unknown. There's just so much that we still don't understand, and it's been, yeah, just challenging and exciting.
I think that leads to one of our other, favorite question, my favorite question that was submitted. How much sleep are you getting?
It varies. So we had a big presentation last week and I was not getting very much sleep at all. And even when I would go to sleep, I would have dreams about questions that might come up during the presentation. So yeah, you know, on and off. During my deployments, we were working really long hours and that wasn't very much sleep either. Because your brain just keeps going even when you leave the office or, you know, close your laptop.
Oh, we did have a question in the chat about the ultra cold freezers. The cold one is the Pfizer one. So I think there are other companies. Is that the coldest one?
That is the ultra cold.
Okay.
Very good.
Is that the only manufacturer of it?
That is Pfizer is the only manufacturer with an ultra cold vaccine, but the other vaccines will require, you know, cold chain logistics.
Okay. Oh, that's right, because the Pfizer one's the RNA vaccine, right? That's.
Yes. Yeah.
I think so. Oh, and because what is the other vaccine, the other big one trial, the London-based company?
Moderna.
Moderna, yes. And JJ, Moderna is the adenovirus vector vaccine. So just remember that one, JJ.
Yes, that's correct.
Someone's doing a project on adenoviruses, so they need to know that.
Nice. You guys are very quick with it.
And then, all right, let's see. Oh, I know we're almost out of time. Let's see. I'm gonna skip to, do you think we will ever determine, could you talk a little bit more about the different vaccines and the differences between them? Maybe we'll wrap up with that, or?
I am not super well versed in like the vaccine components. But I can say that they are hoping that the first phase of vaccine introduction takes place before the end of the year. And hopefully after that, you know, more doses will be developed and that it will be available to the public sometime next year.
And we can talk about, I guess, more of the different types of vaccines next week. But and so, okay, Winston, so if the RNA vaccine ends up being effective and rolled out, it would be the first like major RNA actual vaccine of its kind, I think.
Wow.
Right. And the other one is also very cool because it's called a virus vector vaccine. And what they actually do is they take an adenovirus virus and they kind of transplant like surface proteins of the COVID-19 virus and like attach it to the adenovirus. And so that way your body initiates a new immune response, hopefully to protect you from COVID without actually having to be exposed to the entire virus. But that's some cool stuff. And you know, I guess before we go, I'll just let you know, did you know Nicole Carter is working on one of the Moderna vaccine trials in San Diego? Yeah.
No, I didn't know that.
Yeah.
That's so cool.
And how much do you have to go? I know you have a meeting.
My next call is at 4, so I'm okay right now.
Okay, all right. I'll try and wrap
your time.
Okay. All right, thank you. And one fun fact, I'll ask you guys a question. So Miss Werner lives in Atlanta, and that is where CDC is headquartered. Does anyone know or want to look up and then tell us why CDC is headquartered in Atlanta and not Washington, D.C.?
So if something goes wrong in Washington, D.C., then the CDC won't go as well.
That sounds like the Walking Dead answer.
Yeah. Although in the Walking,
I remember that was one of the main points of the post-nuclear war plan that the U.S. has. The CDC is in Atlanta, so that way, if Washington, D.C. is directly targeted, then all the staff can flock there.
Huh.
Oh, I don't think I knew that.
Online, it said it was after a war. It was after a war. They didn't want the soldiers from World War I or World War II bringing back a disease, so they put it in Atlanta instead of the capital.
Oh.
So, Ms. Warner, isn't it because I always thought it was because it was malaria, right? Isn't
Yeah,
the official story? Maybe we've been lied to.
and it's there were ties to Emory University. So Emory University, which is based here and actually right next door to the CDC campus, it was leadership from Emory University that I think headed up the beginnings of CDC.
And it wasn't it also because there used to actually be malaria in the United States in the South, right? And so they needed to, I guess it was geographically also closer to where that was a big public health issue. And so, and they did successfully eradicate malaria in the United States. We don't have to worry about that anymore here. So,
Yeah, fun fact. Do you guys know how they did that? Because we don't have a malaria vaccine. So how do you think they got rid of malaria in the US?
Oh, they just let everyone get it and
Isolated the people who had it.
Oh, okay.
So I heard two answers. They isolated people that had it. That would only work if it was infectious among people, which it's not. It can only be spread by mosquitoes. A mosquito has to bite you. You can't get malaria from someone else. And then the other answer was they just let everybody get it, which also is incorrect because you can get malaria many, many times. You don't get it once and then gain immunity. So the answer is they got, sorry?
Would it be a bacteriophage maybe that could kill off malaria?
No, that's a good thought though.
I guess we still don't have a cure for it. So do we?
No,
Because
we do not.
Yeah, because in the future there might be genetic engineering in mosquitoes to get rid of it.
Yeah, they are doing a lot of research around mosquitoes, and I think that's a little, yeah, it's far off. But anyway, the answer is what they did was get rid of a lot of standing water. So at that time in the United States, there weren't a lot of, sewers or sanitation and hygiene. Like think of today, like how we have garbage pickup trucks pick up the garbage from our houses. Back then that didn't exist. So there was a lot of waste everywhere and a lot of standing water because after it would rain, the water wouldn't drain. There were a lot of areas in the US that just had sitting water. And so when they got rid of it, what they did was remove all of the areas where mosquitoes could breed. So mosquitoes can only live in the US in most places part of the year. And if you remove their breeding ground, then you get rid of the capacity for them to exist and transmit disease.
Yeah, and so one way, so if you don't have a cure, so malaria is transmitted through a mosquito, but if you can't cure the actual pathogen, malaria, you can stop the transmission through the vector or through the mosquito.
Yeah, malaria is a parasite. It's a parasitic infection.
Plasmodium.
Yes,
Yeah.
that's correct.
Yeah, and so they are eukaryotic cells for everyone. Just to know. All right. And then let's see. All right, I guess this will be a good wrap-up question. So when do you think COVID cases will dwindle to the point where we can return to normal life, if at all? And what changes do you think will still continue on after we're past COVID?
That is a very good and a very difficult question. I think that a lot of people are putting their hope in the vaccine, and what we know about vaccines is that they work. They are an amazing accomplishment in the field of public health. And once people, can have immunity without having to get the disease, then it decreases the likelihood of, or the possibility for the disease, the infectious disease, to continue to exist. So, have you guys discussed like herd immunity at all? Okay, I'll just touch on that.
Enough people have to be inoculated against the virus, so when they get it, other people don't get it. Isn't
Right.
So for example, the MMR vaccine only works like at 95%, and other various viruses have different levels as well.
Right. So you're talking about the efficacy of vaccines, and that's really important in their development. But when you are thinking about herd immunity, it's really thinking about the number of the people in the population that are immune to the disease. So for COVID, we don't know exactly how long you're immune to the disease after you have it. There's a lot of research surrounding that area. But if you can immunize or vaccinate 80% or 50% of the population, and then another percentage, say 25% of your population gets the disease, then that's a lot of the people who have immunity and are not going to be vulnerable to reinfection. So then the host is unavailable, right? An infection, a disease needs a host. And so if immunity is above or at 80% then it dissipates the ability of the infection to continue transmission.
And what determines herd immunity is kind of how much movement, or kind of what determines what percentage of people need to be immune for herd immunity to take effect, is related to how infectious the disease is. So like how many people one person is likely to transmit it to, and also that's also related to the movement within and in and out of a community as well.
So then I think, just to wrap up that question, COVID, like previous flus, they're expecting that it will have 2 epidemic curves, right? And right now, the United States is still in the first epidemic curve. They think that the vaccine will likely come when we're in the second epidemic curve or wave of the outbreak. So like Europe right now, they're in their second wave. And so France and Spain and Germany, they're shutting down all their businesses again, like they did in the beginning of 2020, because they just want to get through it. They want to see the number of cases decrease to a point where the infection isn't spreading anymore, or it's not spreading as pervasively. And so in the US, we're still in the first epidemic curve. And I think that it's going to be interesting to see how long it will take us to get through this, and then at what point in these 2 waves will the vaccine be introduced, and then that will affect the height or how many cases we face in the second wave of the epidemic. And then after that, hopefully life will somewhat return to normal. And I think that people are going to be much more conscientious about hygiene and like washing your hands, covering your mouth when you sneeze or cough, things like that. I think that our generation, your generation, are going to be a little bit more adamant about just taking public health and community health a little more seriously.
And I see one quick question in the chat, or actually, Max, you've had your hand up for a while. Do you have a question? No? All right, Isam?
Yeah.
Oh, sorry, go ahead.
So you may know this person, but so you know how Trump, he got the virus like a day right after he got exposed, right? And
Yeah.
then he somehow was cured like after a day or 2. Do you believe that this is actually true?
All right.
Trump was in the hospital for almost a week.
Uh,
All right, Max.
Trump was in the hospital for a few days, and
Make sure you don't drink bleach.
All right. Hey, okay, Jerry,
Nope.
please. All right, guys, let's. Sorry. Okay, thanks, Max. We're gonna move on after that one. Isam, do you have a question?
Yeah.
It's not politically.
It's not.
Okay, thank you.
So, in the U.S., like coronavirus got really bad in like March, but do you think there might have been cases in flu season that people thought were just the flu, but it was coronavirus in America? Like, as if people traveled back from countries that had strong coronavirus, like right before the outbreak, do you think it's possible that people in America had it before it was diagnosed?
Yes, actually, that's a really good question. There has been a lot of research that identifies likely cases dating as far back as like December of 2019. So I think that what you said is exactly right. I think that it was identified after it had been on the news and people started recognizing the symptoms, and then they went to medical providers and asked specifically like, well, I was just in China and I have this and this, so I think that I should be tested for this disease. So yeah, I think you're right. I think that it definitely was here prior to the initial reaction.
And do you have time for one more quick question? I know we're cutting you. We're already over. I'm sorry.
That's okay.
All right. Why do we have a question in the chat from Winston? Why do we have more than one epidemic curve or spike? Why do we have more than one peak?
Yeah, so I think you might have to help me with this answer. I think that diseases or viruses have natural like disease characteristics. And so what we know about COVID-19 is that it's a coronavirus and that its characteristics match other coronaviruses, right? So this family of viruses have similar genetic makeups, and then they present similarly, right? Because they're related. So we know that these characteristics, they present, I guess, in ways that are just specific to the virus. So one comparison that's made a lot is to the Spanish flu, and that was in
1918
to 1920, and that the trend of that virus or the characteristics of that virus was the same. It had a strong peak in the first wave, and then they thought it was gone, and it came back, and I guess that probably comes back to immunity, right?
Yeah, people stopping before knowing it, because you still have those asymptomatic people, right? Or the people who are still, or post-symptomatic even too, but.
Right.
Yeah.
And think about like all of the people in the US or who aren't sick, but then like in Georgia shut down. And then the governor said, no, we're not going to shut down. We're going to open back up. So our cases had started to go down, but then everybody started going back out into public. And the people who had stayed home then are becoming vulnerable to catching the virus again. So it's like after that first curve goes down, then people think, okay, we're going back to normal. They go back into real life, normal routine activities. They're not immune because they had stayed home to avoid getting sick. And then they are vulnerable to getting infected. And so then those people who don't have immunity, they get sick. And I think that's what contributes to the second wave.
And I know in one of our earlier section today, we did talk about SARS compared to COVID-19 and how, you know, the percentage of asymptomatic people and the long incubation period before people become symptomatic is really contributing to making this more difficult, because with SARS, I think the incubation period was only a couple days. It was like 2 days or something, and almost everyone became ill and symptomatic. Right. So it was much easier to isolate and like disrupt that transmission for SARS.
Right. But here the incubation period is 14 days. And think about how many people you come into contact with in 14 days. It's crazy.
Yeah.
Wait, can I ask one real quick question? Like, it's gonna be really quick.
Is it about the
No, it's
president?
something political.
Okay.
Okay, so me and Andy, like over winter break, we went to China, and then we came back in like a week after the beginning of January, and then a week after that, we like got really sick, and we were wondering if that could have been COVID.
Yeah, I mean it could. Were you in Wuhan province?
No, we were not.
Honestly,
Aren't you at Harbin?
a lot of people get sick. Like I travel for work all the time, and almost every time I come home, I get sick a week later. And there are a lot of factors that play into that. So I don't know about like your travel history or where you went, but like when you go through airports, when you sit on an airplane, when you disrupt your sleep cycle or disrupt your normal eating, like what you eat normally, all of those things can contribute to making you sick. And so I don't know if you had COVID, like you could go and try and get your serology tested to see if you have, you know, markers that indicate that you did have it, like an antibody test, and then you would know if you did.
But even though those are like still evolving and somewhat, they're not definitive right now.
They're not definitive, and like COVID tests, they're not always accurate either.
Okay, thank you.
Oh, hang on, Haley. One sorry. All right, you guys. I think we do have to wrap it up because Miss Warner does have a meeting to go to. But I just want to say thank you so much. I think everyone really found this really interesting and enjoyed this Q and A, and hopefully learned a lot. So everyone, thank you guys all for participating and coming today, and a big thank you to Ms. Warner for taking the time to talk to us about her work as an epidemiologist and on the COVID-19 response. So
cool. Thanks, you guys.
Thank you so much. All right.
Yeah. Have a great day.
Okay, bye.
Be
Bye,
nice to
you too.
All right, bye, everyone.
Bye.
Bye.
Thank you.
Bye.
Thank
Bye.
you.
Isama.